Hi guys, welcome back to the channel after the weekend. Hope you had a good weekend. और बहुत सारे फेस्टिवल थे, रामनवमी एंड ये वाले नवरात्र भी होते हैं, ईद था, तो होप यू हैव एंजॉयड योर वीकेंड. So last week we have started with squamous cell carcinoma of gingiva and we'll be continuing that. Okay, let's start. Squamous cell carcinoma of gingiva, clinical presentation we have seen. Okay, we'll go through once. It is an indolent, slow growing, and has a low propensity to metastasize. Little less than 10% of all intraoral carcinoma are present as a red white thickening of the marginal and interdental gingiva. This carcinoma may not be very infiltrative, but its surface spread may be extensive. Frequently, the entire gingiva on each side of the midline is involved, but it includes only the attached gingiva. Now, coming to the differential diagnosis, first is chronic persistent periodontitis, second is lichen planus of attached gingiva, third is pemphigoid forms, and fourth is benign hyperkeratosis form of clinical leukoplakia. So these all pre-malignant lesion or infection are mainly the differential diagnosis for squamous cell carcinoma of gingiva. Now coming to diagnostic workup is as same for all other intraoral carcinoma. We begin with oral and head and neck examination, followed by mirror or fibro-optic examination of laryngopharynx, followed by TNM staging and incisional biopsy. It is important to biopsy such lesion to include periosteum for the depth of invasion of carcinoma. तो periosteum ज़रूर include करना है when we are doing incisional biopsy for squamous cell carcinoma of gingiva. Now, periapical and panoramic radiograph required to assess area of possible bony invasion. Histopathology ज़्यादा कुछ नहीं है. Pulses are well differentiated and second is lack of marked cellular atypia. तो cellular atypia उतना prominently नहीं दिखता और they are well differentiated carcinoma. Now coming to the treatment plan. It is treated with the excision of soft tissue including the alveolar bone. तो पूरा excision होगा complete with the bone. The excision must include both buccal and lingual gingiva. The bone is resected to the level of the root apices superior to the mandibular canal in posterior mandible and short of the sinus floor or nasal floor in maxilla. तो रूट अपाइसिस तक बोन रिसेक्ट करते हैं superior to the mandibular canal in mandible and in maxilla short of the sinus floor or nasal floor. Now, frozen section are extremely important because of the diffuse spread along the marginal gingiva. तो frozen section बहुत important है because they have a diffuse spread. Even if clear margins are established, biopsy of the gingiva posterior to the clear margin is recommended because of the satellite lesion and skip areas of uninvolved gingiva with cancer. तो ये ऐसा बोल रहे हैं कि अगर क्लियर मार्जिन स्टैब्लिश हो गई है लेकिन हमको बायोप्सी उसके पोस्टीरियर भी लेना है because of satellite lesion and skip areas of uninvolved gingiva with cancer. कभी कभी ऐसा हो जाता है कि कोई एरिया स्किप करके आगे uninvolved gingiva with cancer. Because of the low propensity of gingival carcinoma to undergo local lymph node metastasis, a prophylactic neck dissection is not recommended. क्योंकि low propensity होती है इसलिए prophylactic neck dissection is generally not recommended. Most patients require a secondary vestibuloplasty for prosthetic rehabilitation. Prosthetic rehabilitation लगता है mainly and that is done by secondary vestibuloplasty. That's all for today. We'll be continuing this in the next class. Till then, like, share, subscribe and comment. Bye.